Okay, it looks like it's top of the hour. Thank you everyone for joining us today for our webinar. Just a couple quick things before we get started. We'll have some time at the end of the webinar for questions, so please submit those throughout the webinar via the chat function. And certificates will be available this Friday by logging into your account. Dr. Hoban, if you'd like to get started, go right ahead.
All right, thank you. And thanks everyone for joining us. So I'm going to talk today about early initiation as standard of care. And again, we should have time for questions at the end. So we'll be discussing any products, drugs, devices, etc. And my only disclosure is past and previous honoraria from Medela, but independent of sponsor input. So I hope you'll enjoy the talk today. We're going to discuss some common risk factors, specifically that impact initiation and how they might be mitigated. We're going to briefly review lactation physiology in the transition from pregnancy to the early postpartum period and how that might be influenced by initiation behaviors. And finally, we're going to share the evidence for a proactive approach to lactation to facilitate meeting lactation goals. And finally, my one additional disclosure actually is that I'm a working mother, and I just got a call about an hour ago that my kid's school closed due to COVID outbreak. So my kids are home, so I am praying that they don't Zoom bomb you. So we'll keep our fingers crossed. So we'll start with a case. We have a 37-year-old G1, so an older mom, we've all been there, and a first-time mom. It's an IVF pregnancy due to PCOS. But mom hasn't had other pregnancy complications. And she says she intends to breastfeed. And unfortunately, her water breaks about a month early, and so she's induced and has a vaginal delivery. Peds is called for meconium, and unfortunately, the baby has a bit of respiratory distress, so has to go to the NICU to be monitored for tachypnea. The baby's in the NICU, is on a bit of oxygen, is on some IV fluids, so unfortunately can't go to or doesn't go skin to skin immediately. Nurses are busy, the doctor is busy, so there's really no discussions regarding lactation. The baby, though, luckily recovers quickly and goes back to mom at 8 hours of life. The mom had wanted to breastfeed, so she tries to put baby to breast, kind of latches for a moment and falls asleep, latches again and falls asleep, and doesn't really seem to get anything when she's at breast. So the mom partner says the baby has to eat, and so gives the baby a 2-ounce bottle of formula or 60 ml at Canada. Sorry, I'm American. And the baby takes most of that with some small spit ups. Now the mom tries breastfeeding a few times, but she has increasing discomfort. It's really having a lot of nipple pain. And so the mom asks for LC help, but it's the weekend, and unfortunately, this hospital doesn't have any lactation support on Sundays. But the nurse takes a look and she diagnoses a lipstick nipple, so meaning that the mom's nipples look very asymmetric after the baby goes to breast, which is a good sign that the baby has a shallow latch, really an ineffective latch. But now, unfortunately, the mom has nipple breakdown and has a blister. So because of this nipple pain and the baby is sleepy and not latching well, the family gives formula, and the baby's given a bottle around the clock every couple hours. Sorry for my child stomping up the stairs. The glucoses are fine, and the baby experiences minimal weight loss. Now, luckily, the lactation consultant comes in on Monday, so about a day later, and does work on positioning the baby. The mom is overweight, has larger breasts, so has had some challenges with getting good position. They work on deepening the latch, keeping the baby awake, etc. But unfortunately, the LC is only able to witness one feed before mom and baby are quickly discharged home. Now at home, mom's tired, very appropriate, she's just delivered, but her partner decides to help by feeding the baby formula during the night for the first couple nights. But luckily, the mom's nipples are healing, and so over the next couple days, she works on breastfeeding and intermittently attempts to breastfeed as well as bottle feeding with formula. So she doesn't breastfeed with every single session. Sometimes she just gives the baby formula. There's no, unfortunately, lactation follow-up arranged, and mom does not have a pump. Her milk comes in at day 5, so a little bit late, but she's able to actually partially breastfeed for a few months. And so you could definitely argue partial breastfeeding for 3 months is great. The baby definitely got some benefits of breast milk, but definitely be room for improvement in this story. And I know there's lots of risk factors, and the story sounds a little bit absurd, but unfortunately, we really see this quite commonly in these combinations of different practices and different risk factors. So we're going to drill down a bit into some parts of this story, hopefully to help everyone, help our patients do better. So what were the concerns here? So we had delays in early breastfeeding or stimulation. So if you remember, the baby came back from the NICU at about 8 hours, and mom hadn't done any pumping. And then the baby was only really intermittently latching. There was a lack of consistent and frequent breast stimulation. So again, no pumping for the first quite a few hours. And then once baby did go to breast, then there was another kind of overnight period without any stimulation. And lack of effective breast stimulation. So this late preterm baby had an ineffective latch, and mom again wasn't pumping after putting the baby to breast. And these stories are quite reflective of what really happens in Canada and North America. So the majority of moms do initiate lactation, so that's fabulous. But unfortunately, like this mom, by the time we get to a couple months, our numbers have really fallen quite dramatically. And by the time we get to 6 months, which should be the kind of minimum required or minimum recommended by the WHO, for example, only about a quarter of our families are still breastfeeding. And when you ask parents why this is, the most common response is that they don't have enough milk. Now, this can be a subjective feeling or an objective feeling due to infant weight loss, for example, or they report just general difficulty with breastfeeding. And so we're going to look into how we can potentially affect these concerns by starting really early on. So we have to look at the various risk factors that go into each breastfeeding story. So some are unmodifiable. So for example, with the infant, they could have a very premature delivery. But most of these are known around the time of birth or even before birth, or known by the first feed. So these are problems that we can anticipate. We can discuss prenatally, and we can start to plan and hopefully mitigate these challenges. In other circumstances, you have an inability or a reduced ability to feed at breast, so the premature babies we talked about. But that can even include babies like this one that aren't in the NICU or aren't there for very long, which they're late preterm and they might be sleepy or have a poor latch. Congenital anomalies such as a cleft lip or palate, in which they may have challenges getting adequate suction at the breast. Or babies that are NPO initially or soon after birth. And this includes babies that are often term or near term, who might have to be admitted for surgical evaluation, for example, who are very sick with meconium aspiration, sepsis, birth asphyxia. But this also includes babies who aren't so sick, but might be separated from their moms. So they can feed, but they're in the NICU because of jaundice or because of hypoglycemia. And it's these last two categories that are more challenging, because typically these are what would have expected to have been healthy term or near-term babies. And so moms didn't necessarily have a different kind of birth plan or a different kind of breastfeeding plan than their typical normal healthy baby. And so in cases like this, it's a big challenge when the mom or the baby is unexpectedly sick. But we need to help families do a rapid change in their mental model and really quickly switch to a different kind of support system. We need a fast transition to pumping in these cases, again, to really help initiation, which can help her meet her long-term goals. So we talked about unmodifiable risk factors, but there's clearly a lot of things we can modify as well about the infant risk factors. And a big one, which I'll go into more detail later, is unnecessary formula supplementation. So human milk substitutes, they clearly have their place. They can be necessary if there is significant weight loss early on, for example, if a baby has hypoglycemia that doesn't respond to breastfeeding or glucose gel. it's definitely indicated. But there are many circumstances in which it's not necessary. So we really need parents and provider education about what a healthy infant actually needs. Because when you actually talk to families, or even when I've talked to my non-medical friends, people don't actually know that the second you deliver, you don't have like copious amounts of milk that's ready to go. And they don't know that babies actually don't have a lot of fluid or glucose requirements in the first day or so if they're born at term. This little kind of cute crochet picture here is actually from a crafting website from Etsy, which I love. It's a really kind of cute teaching tool, and it's showing the size of infants' stomachs in the first week of life. So you see a cherry for the first day of life, a walnut was day 3, and I think that's an apricot for day 5, and then an egg for after the first week or so. And so it's a nice visual tool to really show how little milk these babies actually can fit in their stomach, or how little they actually need. And it's hard when babies are going to the breast because when you can't tell how little or how much they're initially getting. And so parents don't realize, again, how little colostrum they might make. It's only a couple mLs in the first day, as shown in this picture. Whereas if you're giving baby formula, like this, this the standard pre-made formula container that's at most hospitals, it's 2 ounces or 60 mLs. So that's way more milk in a single feed than most mothers would make in colostrum in the first entire 24 hours of life. So we really, again, need to educate families when they think that the baby needs to eat or needs more milk, that really, like if they're healthy in term and their sugar's okay, like they should be okay to just go to the breast. So how about maternal risk factors? So unfortunately, a lot of these risk factors are very common and are becoming more common. So a lot of our smaller families, a lot of moms are now first-time moms. C-sections are frequent. Moms are older now when they're delivering, and many, many more moms are overweight or are obese. And all of these risk factors can affect lactogenesis timing. We can't do a lot about these, but as healthcare providers, what we can really affect is parent education about the importance of lactation initiation and when and how often this happens. That's really what I'm going to focus on. So lactation challenges are due to this complex interplay. There's a lot going on. There's sociodemographic factors. There's these maternal fetal health factors that we talked about. And these can directly or indirectly affect a lot of things. So maternal behaviors. So is she pumping? Is she direct breastfeeding? Is she doing some combination? That can affect supply and demand. A screaming baby is much more likely to get put to breast than a silent pump sitting in the corner of a hospital room. It affects their infant-mother dynamic. So if they're separated, if baby's in the NICU, if mom, God forbid, is in the ICU. And these all affect the timing of when mom's milk comes in, as well as the overall ability to make milk in the short and long term. Due to these risk factors we talked about, it can be due to incomplete breast development. So if the mom is delivering at 24 weeks, she missed many months of what would have been completion of breast development during pregnancy. But the most important thing, and fortunately, the thing that we can affect as healthcare providers is inadequate breast stimulation, whether it's by the infant or a pump or otherwise. And we know that issues with initiation, so those first couple of days, they're linked to most long-term lactation challenges and early cessation, whether families realize this or not. And there's really a physiologic basis behind this. And so if we're able to educate our staff and educate our families about this importance, we can really prevent a lot of these long-term concerns about not enough milk. So I'm going to briefly review the physiology of lactation. If you guys have seen some of my talks, some of these slides are review. There's not a lot of novel ways to discuss physiology. It is what it is. But again, I think it's really critical to understand the recommendations, to understand where they're coming from a physiologic basis. So during pregnancy, you start to make the ability to make milk. But you don't actually build milk up because the cells in the breast are leaky. they're not stuck tightly together. So your milk components are found in the urine, actually. Now, once the mom delivers, you go from secretory differentiation to secretory activation, so lactogenesis 1 to 2. And lactogenesis 2 is also kind of that feeling when your milk comes in. Now, in a healthy term delivery, this is typically within 72 hours. Now, even moms that don't actually put the baby to breast or don't pump often can have their milk come in. So it's not necessarily reliant on breast stimulation, but it can be influenced. For example, in this paper from a couple of years ago, from my group at my former group in Chicago, we looked at very premature babies, and we saw that moms who pumped more frequently in the first few days had their milk come in earlier. Now, why does this happen? So there's many complex hormonal changes that occur in the immediate postpartum period, but what really triggers lactogenesis 2 is this rapid decline in progesterone when the placenta is delivered. So you get this plummeting progesterone, and then progesterone has been inhibiting prolactin. So stay with me, we're almost done with the physiology part. So prolactin then catalyzes the closure of those tight junctions. So those leaky cells we talked about, prolactin basically tightens them up and lactose gets kind of stuck in the cell. Once that gets stuck, water comes into and you make milk. And that's when moms get that kind of warm, lumpy, funny, tingly feeling in the breasts that says that their milk is coming in. But that's only the first step in meeting lactation goals. You have to have your milk come in or have secretory activation. But after that, you have many important additional steps before copious milk production. And these steps require, unlike the previous ones, stimulation and milk removal. Each breast is controlled locally, so if you only pump or use one breast, that's the only one that's going to make milk. And these first days in particular, but definitely the first 2 weeks, are really vital for what I've termed breast programming. So really telling the breast what it's supposed to do, setting it up for success, not only to make milk that day, but to make milk weeks and months and potentially even years down the road. All of those long-term plans really come into place this first couple days. So prolactin is super important. We already talked about how it makes those junctions tight, but it also actually makes more lactocytes. So it makes more milk-making cells, which is super important if the mom delivers early and didn't experience that full pregnancy-induced breast development. Now, in addition to making more lactocytes, it prevents the death of lactocytes. So you get kind of a 2-for-1. You get more and more milk-making cells. And it's really critical in these first couple weeks to have high concentrations of prolactin. Not so much later during lactation maintenance, but you need to get to initiation before you can get to maintenance. And so having those high levels in the first couple weeks is vital, and conversely, low levels can permanently jeopardize your milk production. Again, setting moms up for that concern that they don't have enough milk months down the road. So prolactin sounds great. So how do I get more prolactin? So you get prolactin, especially in the first couple weeks with pumping or with the baby going to breast. You get it with suction. So you can see in these two graphics, you can see that the changes in the bar is from pre-stimulation versus post-stimulation. So after suction, your prolactin level really shoots up, especially in the first couple weeks. You can see as you get multiple days, more days or months postpartum, that decreases less, but it's really, really huge in the first couple days. So early, effective, and frequent expression gives you more and more and more prolactin surges. And remember that prolactin builds milk-making cells. So really, really critical for optimal breast programming. And the really kind of important thing with pumping in the first couple of weeks is that even when you close those tight junctions, we had thought that other than mastitis, that they stayed closed. But we showed for the first time a few years ago that they can actually reopen with changes in pumping behaviors. So this was a study done in very preterm moms. I won't go into a lot of details, but we basically looked at biomarkers in the milk, which tells you indirectly when those junctions are closed. The mom on the left, that red line that drops, is sodium. So that means sodium levels are low, junctions are closed. Great, perfect. Now the mom on the right, she wasn't pumping as frequently as the other mom, and her red line, her sodium, kind of goes a bit all over the place. But importantly, you can see that when she goes from pumping about 4 times a day to pumping like twice a day, immediately her salt levels skyrocket, and they go really back to similar levels to they had in colostrum. And so just from a single day of pumping, you can tell that just from that single changes in behavior, she really reopened her tight junctions. And whether those can close again would really depend on her pumping behaviors. Therefore, especially in the first 2 weeks, continued lactation support is really incredibly, incredibly vital. Now, this really focuses on those first 2 weeks. And again, why that's so important is we really want to make sure that mom is able to program the breasts to have a really good options later. So we talked about that prolactin makes more lactocytes. And as you make more and you keep pumping, you really then maintain those lactocytes. Conversely, if you don't pump or don't put the baby to breast enough, those lactocytes then, they think they're not needed and apoptosis occurs. So they start to get pruned. I'm so sorry, my child's iPad keeps going off and I can't figure out how to turn it off. Okay. I'm sorry, living the dream of working mother. Okay. Anyway, so when these lactocytes are pruned in the first 2 weeks, then moms really don't have the option to be able to exclusively breastfeed later. And so if we're able to give her these good options and have her pump frequently in the first 2 weeks, then she can make the decision to decide, do I want to exclusively breastfeed? Do I want to breastfeed for weeks or months or years? If we don't set her up for success in the first few weeks, she doesn't have those choices. I'm sorry, I'm trying to turn off my child's iPad and I can't. Okay, I'm sorry, I apologize. I hate COVID. I'm sorry that my kids are home. Okay, so what can I do with a healthcare provider to really help moms optimize their goals? So with a healthy term baby, really following baby-friendly policies. So initiating breastfeeding within an hour, even with a C-section. No formula supplementation unless it's indicated. And again, sometimes it is, and that's fine. But if it's not, we really need to educate families about why it's not needed. Rooming and on-demand breastfeeding are really important for all babies, but definitely for term babies. And we know that hospitals who have these kind of policies in place, where it's just kind of the standard, they're more likely to have moms who exclusively breastfeed at discharge. Now, breastfeeding that first hour, when you have a vaginal delivery, isn't that difficult. But when you have a C-section, that can be significantly challenging. But we know that when hospitals really have policies in place, that can really set parents up for success. So this was a case from a developing setting in which they had really good success with getting babies to breast even after C-section. And they did that by designating a specific person who was the baby's kind of breast friend, that person whose job it was to make sure the infant goes to breast. And it was just as important as any other order in the chart. So giving the mom pain medication, for example, as well as putting the baby to breast were vital. I'm sorry, one second. I can't stop my kid's iPad from going up. I'm so okay, thank you. I'm so sorry. My mother won't stop calling my child on the iPad. Okay. Anyway, I'm sorry. So with breastfeeding, again, in that first hour, they realized that if the mom isn't able to, mom needs to be breastfeeding in the operating theater or in the PACU, because if they wait until the baby gets to the floor, it will really take more than the first hour or two. Continuing on with the healthy term baby, so the importance of skin to skin. So this was a recent meta-analysis of 9 studies from around the world. They found that immediate skin to skin was associated with increasing success of a first breastfeed. So you can see in this visual here on the right, the red box shows that the intervention was more successful than the control. So in this case, again, increased success by the infant breastfeeding assessment tool. And then increased duration of the first breastfeed. So the same visual, again, the red bar suggesting that the intervention is helpful. Now, how about formula supplementation? So again, I don't want to demonize formula. It definitely has a place. A lot of people use it. I definitely had to use it intermittently for my kids. But we know that unnecessary formula supplementation in hospital is associated with increased odds of breastfeeding cessation. So this study is a couple years old, but I think it's important in that they found that formula was often given in hospital due to this perceived insufficient milk supply. So again, not necessarily a proven insufficiency, but this perception. Also given due to poor latch or breastfeeding. So signs of inadequate intake, that can be an indication to give formula. So if the baby's actually lost weight, for example. But in these other concerns with this perceived insufficiency, they're often modifiable with education and support. So again, showing families what babies actually need in those first day or two of life. So these babies who were given, again, unnecessary formula in hospital were nearly twice as likely to not be exclusively breastfeeding at days 30 to 60, and were 3 times more likely to stop breastfeeding by day 60. So again, these first couple of days with unnecessary formula can really set moms up for long-term problems. Now, this was a recent, really large study. It was observational, but it was about 5,000 babies. And they, again, looked at in-hospital formula feeding. So you can see the green line is babies that were breastfed, and this is percentage who are still breastfeeding. And on the horizontal axis, you see how many days. So the green lines are babies who are exclusively breastfed, and the blue lines are babies who received formula in hospital. So they attempted to account for some bias, and they had some conservative estimates, assuming that some formula was medically indicated, as it is. But even with that conservative estimate, which is the dotted lines, they found that in-hospital formula was still associated with a 2.5 times increased likelihood of early weaning in the first few months of life. And importantly, unnecessary formula can affect different populations differently. So if you have a mom who's an experienced breastfeeder, who has multiple previous children, maybe it won't be as big of a deal. But with first-time breastfeeders or those with an initial negative experience of breastfeeding, early formula can actually be much more detrimental than to other populations. In addition, multiple studies have shown that formula is more likely to be offered to racialized populations. And so then you're potentially increasing already pre-existing disparities. Now, that being said, have balancing measures because there are some families who otherwise would say, I'm just not going to breastfeed at all if I can't supplement a bit. I'm worried that my baby's hungry, etc. And so I think with education, that's obviously fine. But it's important to teach them objective signs, again, of insufficient milk supply and when or if the baby actually needs supplementation. There have been studies suggesting that limited volume formula supplementation can be safe for lactation in some cases. So the study from 2 years ago found that in healthy term diets, less than 4 ounces of day of formula in the first month, there was no difference in breastfeeding cessation before 6 months when you compared it to those who fed exclusive breast milk. And this other study from 2019, they wanted to see, okay, so in babies that actually do need formula, so in this case, it was babies who had lost a significant amount of weight in the first few days of life. If you do need formula, how can we potentially decrease this risk to lactation? So in this case, it was an RCT in which they gave babies just 10 mLs of formula as a top-up after every breastfeed. And they found no difference in rates of breastfeeding at 6 or 12 months. So again, if formula is needed or really desired by the family, potentially could be, if we give it in smaller volumes or limited volumes, it might not be harmful to lactation. But what a lot of these risk factors have in common is that parents need education, and I think they all really need proactive lactation support. The problem in a lot of our hospitals is that lactation support is there if there's a problem. But in many cases, moms don't really know if they have a problem. Like, they don't really know what to do. And so waiting until there's a problem can really miss a critical window. So going to the lactation consultant when you don't have enough milk at 2 weeks, well, you really needed to probably address that a few weeks or days prior. So we're really missing that critical time when we wait for there to be a problem. In addition, waiting to see moms as needed when there's an issue like nipple trauma or mastitis, that can really negatively affect a mom's early lactation experience, especially moms who weren't really sure about breastfeeding in the first place, and can really cause them long-term harm to their lactation story. In this recent paper that just came out like 3 months ago, it was retrospective, but again, a very large paper, about 7,000 patients. And they found among healthy term diets, those who had early LC visits in hospital before any formula supplementation were twice as likely to be exclusively breastfeeding. So this makes sense, because if you're given education as to why or when formula supplementation is needed, then often you can kind of word that off. So how about proactive lactation support for the more at-risk mom? So these are multiple other studies that just came out this year. So this was a qualitative study of urban low SES mothers. And they did interviews, and they found that the key determinants of exclusive breastfeeding in hospital were prenatal education, as well as time spent postnatally with practical aspects of latch and positioning. And I think this is really important. I think a lot of people assume that because breastfeeding is natural, it should be easy. You just kind of hold your baby and put them onto the breast. It's actually much more challenging than that, as many people who have breastfed know. And so really giving mom those practical skills of latch are really vital in those first couple of days. This was another recent study of 500 moms who had diabetes. So moms with diabetes are likely to have delayed lactogenesis. And those who saw LCs as an inpatient postpartum had 5 times the odds of any breastfeeding at discharge and 5 times the odds of still breastfeeding at 3 months. So again, these first couple of days with proactive support can really set moms up for success. So all that literature was focused on the healthy term baby. So that's obviously the majority of babies. But we have a lot of other populations who might have special or different needs. So the late preterm, like our baby in our case, they're tricky because they look like term babies. And so people often treat them like term babies, but that's really not appropriate. So like term babies, skin to skin is good, rooming in is good. But unlike term babies, they rapidly fatigue, they can't stay awake, they slip off the nipple, they have a poor latch. And they're also immature, so they won't necessarily be looking for milk at 2 or 3 hours. All of these issues put them at risk for inadequate stimulation and emptying of the breast. So the moms are really at high risk of a low milk supply if they're not pumping afterwards. Because if they have the late term baby at the breast, they might be there for 20 minutes, but they're not actually doing anything. They don't have an effective latch, and they're not getting good suction. And if you remember, if you don't have good suction, you don't have good prolactin surge. And if you don't get a good prolactin surge, the breasts aren't being programmed for long-term success. You're not making more lactocytes. So in this population, proactive lactation and nursing support is very important. There's some evidence for secondary strategies like nipple shields in some circumstances, but what's really important, I think, is education. And with these short hospital stays of these late preterm babies, time is really of the essence. They're often only in hospital for 1 to 3 days. So we really have a lot to do during that short time. So it is important to work on feeding at breast in hospital, especially to get moms to what a good latch is, etc. But in these late preterm babies, I think it's also important to manage expectations that a lot of late preterm babies, they simply can't exclusively breastfeed at breast initially. They probably will be able to, but they need a bit more time. They weren't quite done cooking before they were born. So in this population, in many cases, we have to teach and encourage pumping to build a supply with the expectation that this might be necessary for a little while. And this can be challenging because many of these families, if they deliver just a week or two early, they don't really have that in their mental model. In addition, if moms are going to be pumping in hospital, they need a pump. We need hospitals that have pumps for all moms who need it in hospital, and then they can transition, obviously, once they get home to their own. But most importantly for long-term success in this population, I think is having a support plan for the logistics. So if you think about these late preterm babies, mom has to pump, and then she has to take that pumped milk and feed the baby, and change the baby, and then clean all the pump supplies. When you put all that together, that's easily an hour. And then the baby might be ready to do that again another hour after that. And so there's not enough time in the day to easily do this without assistance. So especially in that first week or two that they're home, until the baby's able to get to breast more effectively, how are they going to do this? Who can help them? And how can we set them up for success? These babies need close outpatient follow-up with lactation to ensure they're able to successfully get to the breast, assuming that's what the family wants, and that there's a lack of significant weight loss or jaundice that can put them at risk. So one good objective way to measure is with test weights. So test weights are very accurate, within 2 grams or so of 2 mLs of intake. And there's been a myriad of evidence of literature over the years showing that they're accurate. But the nice thing about doing it for the late preterm is that they can help moms initially in hospital to determine, obviously, how much the baby took and potential need for a substitute supplementation. But what's really important about doing test weights and then pumping is figuring out if there is an issue, especially in a couple days to a week or two after they get home. So if mom pumps and then there isn't any milk after she pumps, so either the baby is feeding well, in which case there should be a good amount of weight on the test weights, or if they didn't feed well on the test weight and there's no milk when she pumps or little milk, then it's a milk production issue. Whereas if the baby isn't taking a lot of milk and mom is able to get a lot of milk when she pumps, it's a milk removal issue. So you have to figure out, is this an issue with the baby's latch and effective milk removal, and they just need some more time to mature? Or is this an actual milk production issue in which we have to focus on the mom, help her with more pumping, with power pumping for potentially with galacticos eventually at some point. So trying to figure out, again, where the issue lies. So we talked about term babies, late preterm, and now we're getting to our itty bitties, the NICU infants. So with NICU infants, with very premature babies, typically moms are pump dependent for initiation. So they are basically completely at the mercy of technology until the baby is able to effectively feed. We know that providing mother's milk for longer and higher amounts is related to starting to pump early, often, and then having skin to skin. So I'm going to briefly go over some of Leslie Parker's studies, which are very well done studies trying to figure out the timing for early pumping with these at-risk, very low birth weight mothers, or mothers of very low birth weight infants. So with her first RCT, she did double electric pumping before 6 hours versus after 6 hours in a group of mothers. And they found that the mothers who pumped in the first 6 hours made more milk during each of the first 7 days. But they were still making more milk 6 weeks later, which is incredibly important. This would make the difference between exclusive and non-exclusive lactation in this group. They're also more likely to still be lactating at 6 weeks, potentially because they had been more successful with more volumes. But she found that the results were driven by moms who initiated pumping within an hour. And that can be really challenging when you're delivering a very low birth weight infant because the mom is often sick herself. So Dr. Parker then did another study just last year, a larger study, and she really tried to tease out the details of those first 6 hours. So looked at pumping within 60 minutes, at 1 to 3 hours, and then 3 to 6 hours. And luckily, she found that the late group, so the 3 to 6 hour group, they made more milk in the first 3 days and over 6 weeks than the other two groups. Interestingly, the late group actually had more pumps on day 1 and more pumps in the first 5 days. So this seems counterintuitive because they did start pumping a couple hours later. But the group postulated that it was very stressful trying to pump within the first hour or so, and it really didn't have any obvious benefit. So that's helpful from I think from a healthcare standpoint, because it's pretty tough to get moms to pump in the first hour after a difficult delivery. Between the groups of in the different 6 hour windows, there's actually no difference in timing of secretory activation. So you can see in this red box visual that all 3 groups kind of overlap in the colors there. And the same for lactation duration. So no difference as far as when they started in those first 6 hours. So if you start pumping early, hopefully you should be making more milk early. We do know that by day 4, you can already start to differentiate mothers that are more likely to be successful later on. So again, suggesting that very early pumping is critical. Those first couple of days and definitely the first 2 weeks typically determine the future lactation ability. So when moms are able to meet 500 mLs a day as their threshold goal, that makes them much more likely to still be providing breast milk at NICU discharge. So we need to be, again, helping them pump very early to try to get to this goal. So we need to initiate early. We need to initiate often. So ideally, and not going longer than 5 hours to sleep at night. Again, this can be challenging. These moms are often, again, sick themselves and have had challenging deliveries. But when you look at more than 5 hours, you do actually start to get physiologic changes in the breast. And remembering that a healthy term baby would never go that long at night. So you really need to try to do the same things that Mother Nature does and be waking up during the night. Importantly for moms that are pumping, often we see that before we talk to moms more about education, they'll say, well, if I only pump every 6 hours, I get a little more each time, and that makes them feel better. We need to emphasize that it's really, especially that first day or so, those volumes to me aren't really important. In the first couple of weeks, they do become more important, but in that first day or two, I don't care how much milk she makes. What I want her to do is to pump frequently to program the breast, and it's totally normal to get almost nothing or even nothing at all. But this can be really disconcerting to moms that don't know this, and they feel like they're doing something wrong or they're not going to be successful. But really, again, reiterating that this isn't about making milk on that first day or two. This is about programming the breast. So early, often, and effectively. So if a baby can't effectively breastfeed, the gold standard, well, it really depends on what the situation is. If they can't breastfeed at all, that's one thing. If they can partially breastfeed, that can be a different situation. And then babies in which they are already breastfeeding well and mom needs a break to go to the store, that's a different situation. So you really need to know, again, what your use case is. And if they can't breastfeed at all, the gold standard is really a double electric pump, ideally a hospital grade, but if not, at least an individual double electric pump. This double electric pump really programs the breast best for long-term lactation. And I always recommend pumping both breasts at once. It's faster, it's logistically easier. Moms can use, I typically recommend pumping bras. I think they're very helpful. And if you do double pump, you get higher volumes early and for weeks afterwards in this 2016 study compared to single pumping. In addition, although hand expression is commonly taught, hand expression alone is really not adequate in this pump-dependent population. So moms that don't have a baby that can effectively breastfeed at the beginning, they should not be doing hand expression alone. Hand expression alone can be helpful to get out the colostrum, for example, or intermittently in a mom with a term baby who's at the breast, but it alone is not appropriate in this population, and that's because of the changes in the hormonal milieu that you get with pumping versus hand expression. So in a healthy term baby who's at the breast, when they breastfeed, they perform suction and compression, which releases prolactin and oxytocin. Now your electric pump has suction but not compression, and hand expression is the opposite, compression but not suction. But it's only if you remember that suction that causes a prolactin surge. So if you're just doing hand expression, you don't get your prolactin surge. And just as we've talked about multiple times, then you don't get that building of lactocytes, the collision of those tight junctions, etc. There's been multiple studies looking at this. This was a study in a developing setting in which moms were randomized to hand expression, which was widely available, versus double electric pumping. And in those first 10 days, moms made a lot more milk with a double electric pump. But what I think shows this effect of prolactin even more is this study by Lucier in 2015, in which she randomized at-risk mothers, so mothers of premature infants, to either hand express or to double electric pump. Now, the moms that did hand expression made a lot less milk in the first week, so about a third less. But what's even more important is that then it was a crossover study, so the moms that hadn't been hand expressing were then given a pump. Unfortunately, it was already kind of too late. Moms that then switched to pumping after 7 days never caught up to the other group, again showing the importance of really early effective initiation. So with pumping, you need education. In my opinion, really every NICU should have an IBCLC dedicated to the NICU. Unfortunately, this is only true in about half of American NICUs. They're often shared with the rest of the maternity hospital or with the children's hospital. But the NICU is really a unique population that really warrants a lot of support. These moms are pump dependent for initiation as well as maintenance. They, by definition, have parent-infant separation. The moms themselves are often sick and have many risk factors. And they're very stressed. Their child's in the NICU, their baby's sick. It's been well documented that LC involvement is associated with higher proportions of infants receiving any milk, as well as milk feeding at NICU discharge. And we talked about proactive lactation support earlier. I think this is even more important in the NICU. So here at Sick Kids, where we do have a dedicated LC in our NICU, our goal is for them to see all moms or families within 24 hours of admission. Because by definition, again, all are high risk. They're all separated from their families. Moms are all pump dependent for lactation initiation. Importantly, though, bedside nurses are also critical in these first few days. They're the one who talks to families typically first and most frequently. So our bedside nurses are really our partners in talking to moms about the importance of starting pumping at their birth hospital. We recently published our experience here at Sick Kids of a retrospective study of 500 babies. And we did a practice change where we had initially a reactive model, so lactation consults if needed or if there were problems. And we switched to a proactive approach, again, in which we assumed all moms were potentially going to have problems. And we found an increase in the proportion of infants that were fed mother's milk, which in this high-risk population, I think is really exciting. So let's get back to our case. So if you remember, we had a 37-year-old prime-up, PCOS, and overweight with a late preterm baby. The baby was in the NICU, but pretty briefly. Had latch difficulties, mom had nipple trauma, and the baby had formula supplementation. So there was a lot going on. So what are the risk factors? So a lot. So preterm parity, overweight, and PCOS. These can kind of change the hormonal milieu that's necessary for lactogenesis. Late prematurity, we have that baby who's not effectively breastfeeding. They were separated, especially for those critical first couple hours. There was delays in lactation initiation, definitely delays in LC consult or proactive lactation support. And the baby really couldn't feed well at breast, which is okay and is appropriate in the late preterm, but the mother wasn't instructed to pump or to stimulate the breast in the meantime. Baby had unnecessary formula supplementation. We pointed out that the glucose was fine and hadn't had weight loss. And even if he had formula, mom should at least then be pumping in addition. But she went for a long period without breast stimulation while the baby was formula fed. And finally, a lack of outpatient lactation plan and a follow-up. So how is she going to be able to try to get the baby to breast successfully at home? So how could we have supported mama baby? So early, if possible, prenatal. So the mom was being induced for premature rupture. So she could have had prenatal counseling on the importance of mother's milk and early skin to skin. Early, frequent, and effective expression with the baby or with a pump or with both. And that hand expression alone shouldn't be used routinely if you're pump dependent during initiation. It's important to do early attempts at breastfeeding if it's possible, like in this situation, but pumping afterwards until breastfeeding is effective. Proactive lactation support, especially with the basics, latch and positioning, and then education of what's normal. How much do babies need? How do I tell if they're really hungry? What signs are they showing me? And then close monitoring of mother's volumes and baby's intake in those first couple weeks in an at-risk population. So in conclusion, establishing an adequate maternal milk volume is the most important lactation-related responsibility for maternity and neonatal caregivers, but it's really this time-limited event that really should have a sense of urgency. We need education of parents and frontline providers about the norms. And I think proactive LC consults should be universal. Everyone should get them. Lactation initiation relies on early, frequent, effective breast stimulation. And if the baby can't do all three right away, you have to use a pump. It's important though to tell families, especially if they weren't expecting or anticipating or wanting initially to pump, that when they're facilitating initiation with pumping, often it's only temporary. Our goal is to establish a milk supply and then get the baby to the breast, whether that's as an inpatient or an outpatient with lactation support. But most importantly, in early support and early help with initiation, it sets families up to meet their lactation goals, but it also then allows them to choose their lactation goals, not have their goals chosen for them when they actually don't have an adequate supply. So I appreciate your time. Thank you for your patience. I apologize for my children's Zoom calls in the background since they were sent home from school with the COVID exposure. I'm so sorry. Living the dream, but I'm happy to take any questions.
Thank you, Dr. Hoban, for that presentation. And I'm sure that everyone and people were commenting in the chat as you were apologizing for what was going on. We're all used to working at home. As right now, I have my landscapers outside doing fall cleanup and using a vacuum to suck up leaves. So if you hear noise in the background at my home, that's what's going on here. So
it was actually my fault because I told my mom to try to electronically babysit my daughter. So she was trying to Zoom her over and over and over because she kept hanging up. So,
well, you did wonderful. You remained focused during that. You stayed professional. So no worries. We all understand. We do have time for a few questions, and there were a few comments in the chat function, but one of the questions that came in about halfway through was, I'd be interested to know if those who topped off were pumping as well.
Sorry, in one of those.
You had mentioned that some of the babies
in the limited formula study.
Yes,
I believe in that case I think that they were just feeding at breast. but I would need to actually go back. I need to go back and look. I think in those cases, when the babies had experienced significant weight loss, I think the thought that it wasn't a latch issue. But that's an important question. I think if there is any concern that the baby isn't effectively removing milk, definitely pump first and ask questions later.
Someone is asking, any experience with Domperidone?
Domperidone, I assume?
Yes,
Domperidone,
I'm
yes.
sorry. My apologies, I read that wrong.
Very different, but yes and yes. So domperidone is so I'm an American, but I'm working in Canada, and in Canada we do have domperidone that's Health Canada approved. Unfortunately, it is not approved in the U.S. But we do use it relatively frequently, I would say, in our NICU families. I do find, though, in the community that it is overprescribed, that it's seen as a kind of a panacea for any supply issue. When you actually drill down into it, a lot of times it's a milk removal issue. We've had many moms who have come to us in the NICU and say that my doctor told me to try domperidone, but when you ask them how often they're pumping like 4 times a day. And so you really have to first have effective pumping and effective milk removal behaviors. And only, in my opinion, after that has been kind of optimized, then if we still don't have a good supply, then I think there's definitely an opportunity to try domperidone or other galactagogues. But until you've optimized the milk removal, I think we shouldn't be looking at kind of an easy out. Domperidone can have significant side effects, so it's, I think, not something to be taken lightly.
Okay, thank you for explaining that. I just wanted to note that I did post a link to the evaluation in the chat function. If everyone can give us your feedback using that before you leave the webinar, that would be most appreciated. And I'm going through these messages in the chat. Someone had mentioned that hand expression alone when done with nipple stretching has been shown to be sufficient in hospitals in Africa. Would you be able to comment towards that?
I'm actually I'm not familiar with that particular literature. You really do need suction of some form to actually get a good prolactin surge. So actual nipple stretching, I'm not sure if that would be kind of adequate from a suction standpoint. In developing settings, obviously double electric pumps sometimes can be hard to come by, but even a kind of a manual pump, so not hand expression, but a manual pump that uses suction, that can be definitely adequate to get a prolactin surge. You don't get quite as big of a surge as with an electric pump, but you definitely can. But no, I'm interested now. I'll have to look up that literature. I have not heard of nipple stretching. So,
okay, thank you. One of the questions that came in was, how soon and often would you recommend mothers with late preterm infants to pump?
So I think with the late term, I mean, there definitely are some late preterm infants that are great feeders. But I think with any late preterm baby, if there's any concerns about latch, if there's any concerns about intake after that first kind of day or two, when you should start to see some milk coming in, if you're not seeing good swallowing, if you're not with test weights not seeing that the baby's taking some milk, I would be ideally pumping after every single breastfeeding session if you have a baby that really seems to be quite at risk. I think especially those first couple of days, that's ideal, and you can again really set moms up for success. It's a little bit more work on the front end, but it's much easier to do that than to try to play catch up if you realize that at a week or two that the baby's really not been adequately stimulating and you have very little milk supply. Okay. But again, it's important, I think, to have a good plan in place because it's a lot of work. It's a lot of work to do both.
Okay, thank you for answering that. We'll try to sneak in one more quick question. Any stats on long-term pumping more than 9 months?
So, and there's definitely moms that do it, and there are babies that can never go to the breast for one reason or another. There's definitely research out of CHOP and from in Philadelphia and from other centers that have significant success with long-term pumping. I think those tend to be moms that are very motivated and have kind of figured out a plan for home and how they can be supported to help pump, and then have also be feeding the baby and figure out the logistics of that. But it's definitely possible. We do know that putting babies to breast, even for example once a day in the NICU, or very infrequently, is associated with higher risk of higher chance of breastfeeding for longer. So we know that some of that, whether it's skin to skin or whether it's just kind of having the ease of having a baby at breast versus having to pump, we know those moms do tend to provide breast milk for longer when baby is at breast, at least part of the time. But it obviously definitely can be done with long-term exclusive pumping. But those moms have to be, I think, well supported at the beginning, since they are at risk of lower volumes.
Okay, it looks like it's top of the hour. So just a couple quick things before we end the webinar today. I just wanted to remind everyone that your certificates will be available by logging into your account on Friday. And registration is now open for our December 8th webinar. And the 2022 webinar schedule will be available shortly. We'll be sending those out. And thank you so much, Rebecca. Give your kids a high five for doing a great job during the webinar today. They did great, and you did great as well. Thank you so much for presenting for us this valuable information, and enjoy the rest of your day.
Thanks for having me. All right,
Thank
thanks
you.
everyone. Okay, bye.